right. Well, good afternoon and welcome everyone. My name is Jennifer Noel and I am the Program Manager for Education and Outreach at the University of Vermont Center on Rural Addiction. I'm also here with Nellie Stidham, Research Assistant, who has done all of the organizing for this webinar. Thank you for joining us today. The Community Rounds workshop series is a live webinar series held monthly by the UVM Center on Rural Addiction to provide opportunities for health professionals to learn and ask questions. We discuss topics related to science-based best practices for substance use disorders, and sessions usually include about 45 minutes of presentation, followed by about 15 minutes for questions and conversation. Sometimes we have a little less than 15 minutes to work with. Before we begin today's session, I'd like to go over a couple of reminders. So this presentation is being recorded, and a recording of the session and the slides will be shared following the presentation. You can expect to receive them via email in a few days. At the end of the session, before questions, a short poll will be shared to assist us with our evaluation, and we would love to have you complete this poll. If people are comfortable, please use the chat box to introduce yourself to the group by sharing your name and your organization and what community that you're coming from. And you can start doing that anytime. We would remind you to select panelists and attendees when you do that so that everybody can see your remarks. And then if you want to ask a question, please use the Q&A box shown here. We will do our best to address all the questions at the end of the session, but if we run out of time, we can follow up with you via email. We also recommend that you choose speaker view during the webinar, so you only see the presenter speaking and you don't have to see the other panelists like me who are here. So before we move into the session, a quick note about our next community rounds, which is on December 1st, and Dr. Brady Heward will present on the social and structural determinants of mental health, substance use, and treatment. And then continuing education credits are available for those who attend the session live. And we actually have a new option, and that's for people to claim credits after just watching the recording of the session. So if you have colleagues who missed this and they would like to watch the recording, you can point them to the recording. This is only available for 30 days after the live webinar, however. We're going to share a link in the chat box during the session, which has instructions on how to claim your credits. And you'll also get instructions via email when you receive the recording and the slides. If you have any questions at all, you can contact us at cora@uvm.edu. We do ask that you claim these credits within 30 days of the live webinar. So I'm going to stop sharing for a moment. And I would like to welcome Dr. Andrea Volonte, who is Associate Professor in the Department of Psychiatry in the Vermont Center on Behavior and Health. And she is the co-director of the Surveillance and Evaluation Core at CORA. She also holds an adjunct faculty appointment in the University of Vermont Department of Psychological Sciences. Dr. Volonte is here today to introduce our speaker, Dr. Alan Budney. So Dr. Volonte, I'll turn it over to you.
Thank you, Jenny, and welcome to all of you who have joined us today. We are thrilled to have Alan Budney here presenting. Alan is a clinical psychologist and professor at the Geisel School of Medicine at Dartmouth, where he directs a NIDA-funded training program on the science of co-occurring disorders. He's also the director of the Treatment Development and Evaluation Core of Dartmouth's Center for Technology and Behavioral Health. Alan has conducted extensive research on innovative behavioral treatments for cannabis use disorders in adolescents and adults. This applied research focused on integrating contingency management interventions with more traditional behavioral therapies and using computer-assisted therapies to enhance access to and the cost effectiveness of these approaches. Dr. Budney also conducted seminal human laboratory and survey studies characterizing the cannabis withdrawal syndrome. Recently, Dr. Budney's studies involve the use of social media to better understand the impact of changing cannabis laws and regulations, and the development of online applications of behavioral economic interventions to modify cannabis use. Dr. Budney is past president of Division 28 and Division 50 of the American Psychological Association and the College on Problems of Drug Dependence. He was a member of the DSM-5 Substance Use Disorders Working Group and consults and serves on multiple scientific advisory organizations related to cannabis consequences and therapeutics. He also previously was at UVM, and we have continued to benefit from his collaborations with us, even across the states. So thank you so much for being with us, Alan, and I'm turning it over to you.
Well, thanks so much, Andrea. Appreciate the introduction. I always try to just like fall asleep during that because I don't want to hear all the different things I've been involved with over the years. It just makes me feel old. Anyway, it's a pleasure to be here. I'm glad y'all could join. I've got to move a couple things around so I can see my slides here. Get rid of that somehow. Anyway, I'm going to talk to you about cannabis, and usually everybody's interested in cannabis and has lots of different questions. The title of my talk you can see here. Let's see if I'm frozen or not frozen. Sometimes that happens. Okay. The alternative title of my talk is Cannabis, Marijuana, Risks and Benefits, Navigating the Swamp. And I think one of the reasons I've been invited is when we talk about cannabis today, it's such a mess out there with all the legal changes, the new products, the different beliefs people have about what cannabis does and doesn't do. And so I hope today to help you figure out how to navigate the swamp and to know a little bit more about what I consider at least is the important knowledge base that you might want to have if you're going to work in the public health space of cannabis. So before I get started, one of the important things when people are talking to you about cannabis is it's controversial and people have lots of biases and different opinions. So you need to know where they're coming from. And this is my background on this slide. You can see I've basically been a researcher for over 30 years, all funded basically by your federal tax dollars at the NIH and NIDA. And most of my work has been on treatment development for people with substance use disorders and mostly with cannabis. So focused on helping people who are interested in quitting or reducing, figuring out better ways to do that. But also conducted a lot of lab and survey studies on the consequences, on withdrawal, and most recently very interested in the changing landscape, how to measure cannabis and cannabis policy. But I've also focused in a little bit of my time once in a while on the therapeutics behind cannabis, the medical marijuana craze, as I like to call it. And I'm on the scientific review board of a few companies that are trying to develop cannabis therapeutics that may be beneficial to folks. A couple personal kind of disclosures. I don't currently use cannabis recreationally or therapeutically. I do have a strong bias against medical marijuana legislation and implementation, and you'll see that come out in my talk. And certainly, I welcome lots of questions, no matter how challenging they are, and I hope to get done in enough time to answer your questions. But I'm always happy to talk about these things later. So there's a lot to talk about. And this is my basic outline. I think a very important first step is make sure we're talking about the same thing, defining cannabis. And then we're going to talk about cannabis as a potentially addictive substance, clinical interventions for cannabis use disorder, challenges for rural populations. And throughout, I'll try to tie things back to rural populations and special circumstances, etc. And a little bit on cannabis or marijuana as a therapeutic, because I think all these things are very relevant to help you form a judgment, a knowledge base about what's going on with cannabis. So I'm going to go do this all pretty rapidly. And I apologize for how quickly I'll move through some things. But again, if you have any questions for clarifications or challenges, etc., just throw them in the Q&A and hopefully we'll get to them later. But there's just not enough time to go into depth about a whole lot. So first of all, why do we need to define cannabis? Doesn't everybody know what cannabis and marijuana is? Well, legalization has made this even more confusing. There's medical and recreational cannabis. Are they different? But there's different compounds, there's CBD, etc. So I hope to bring some light to that for people who aren't so knowledgeable about that. We also need to all be on the same page. And if we're not on the same page, it's hard to figure out, how do I really interpret and communicate research findings? How can you have a meaningful conversation with your friends and family? They may be thinking one thing, you're thinking something else. You can be cross-talking. And most importantly, perhaps, is how do we communicate effectively with the public, patients, our youth, healthcare providers, and policymakers about what do we really know about cannabis, and what do we mean by cannabis when we say cannabis does this or cannabis does that? Before I do that, I'd like to bring the cannabis world back to the topic of this center, which is the rural population. And cannabis, just like all the other substances, is prevalent, used, misused among people that live in rural geographic areas. This is some data from NIDA through the last 5 years. And you can see on the right side of the slide, we highlight the non-metro or the rural folks. And you can see when you talk about any past year cannabis use, it's a little bit less in the rural area. And cannabis use disorder, which is about 1 to 1.5% of the population, is a little bit less, just negligibly, but it is less. But when you talk about among cannabis users, so those that do use cannabis, you actually get a little bit more frequency of more prevalent cannabis. So people that use 100 days or more, so the more frequent users, that's actually a little higher in the rural population. And then all the factors in the rural population that you're probably already aware of, like uninsured, living in poverty, how many people have a college degree, education, residence, or nicotine dependence, they're always, in the wrong direction in terms of the negative direction for those in rural populations. And when you talk about residents in MCL state, what is MCL? That's medical cannabis law. So do you have a medical cannabis law? Rural populated states are less likely, people are less likely to live in one that has medical marijuana laws. So just a few kind of basic epidemiological things to keep in mind when you think about people from the more rural areas. And before I get too much into the definition of cannabis, this is a terrible slide, and I apologize for it. It's pretty big on my big screen, your little screen you keep. But the main point is just to look at the right side. This is the trend over the years, starting in 1976, of daily cannabis use or daily marijuana use. And these are all the different age groups, these lines that are right here. And the main point is, since things are changing here, things tend to be trending in the up direction. We're getting more frequent use across most age groups in our population, and particularly amongst those 18 and older, and to some degree those 18 and younger. But we don't have it on this graph. So things are increasing a little bit as far as we can tell, particularly in the area of frequency of cannabis use. All these age groups aren't necessarily increasing the number of people that use cannabis. Some are, like 19 to 30-year-olds and some of the older age groups, but the frequency is definitely increasing over the past 5 to 10 years. I put this one up here because this is from Monitoring the Future, an annual survey that's done across the country. And what it shows you is the percentage of people in the college age kids that are daily cannabis users. It's about 6%. The same age youth that don't go to college, it's about 15%. So 6% you might feel is a pretty good number. 6 out of 100 college kids use marijuana daily. Well, if you're not going to college in that age, it's 15%. And the reason I put that up here is because it's an example of, again, just of daily cannabis use. But there's more people that don't go to college in rural areas than there are in urban areas. And so this number in the rural areas is, again, higher than it is in other areas. So again, frequent cannabis use is something to keep your finger on. So let's get back to the the original first premise of this talk, which is defining cannabis. Why do we need to do that? Here I'm just showing you a whole bunch of pictures of all the different products that are now available since legalization, and things have changed over the last 10 to 15 years. When I was growing up, in college and high school, this is the only stuff we really had to use mostly over here. Flower up in the left-hand corner, flowers that you could put in a pipe or a joint. Now there are things you can eat, things you can dab, and concentrated products that you can use a blowtorch for. There's creams you can put on, etc., etc. This is an example of things you can smoke or vape in particular. And again, there's the flowers, but there's also these concentrated products that are called shatter or butter, honey oil. And the buds you can smoke, or the flower you can smoke or vape nowadays, is basically about, I always get this, I have to do my calculate, about 4 to 10 times higher than the stuff, again, that was available when I was in college and high school. So everything is a little more potent, and this is an example of a blunt, if you were just wondering. So I talked about high potency. There's products called concentrates that are very potent. So when we talk about potency with cannabis, it's usually about what percent THC, and I'm going to explain that more in a little bit. But in buds, you usually see something nowadays somewhere around 15 to 25%, most frequently sold. And in these concentrated products that look like this, it's anywhere from 65 to 90% THC, which basically just means the amount you need to use to get high is much, much less. You might take just one puff, one toke, 2 or 3 tokes on this, and you have a pretty good high. Here you need a few more tokes, and the stuff that was available a long time ago, you might need to smoke a half a joint or a whole joint to get the same effect. There's also these edible products, dark chocolate. They seem to like to put it in chocolate, or dark chocolate in particular, because it's healthy, and the promotion theme is that cannabis is a healthy product. But it's gummies, or everybody's heard about gummies nowadays. There's also creams, salves, lotions, etc., etc. And these products I showed you, all these things, you can see up top, I have THC-laden cannabis. We're going to get back to that a little bit more, but these are things that get you high because they have delta-9 THC in them. And then when I move to this slide, there's also CBD products, which are also referred to plenty of times as cannabis. But they really basically have no THC, or just negligible amounts of THC, and they do not get you high. And they're put in all kinds of products, from shampoos to drinks to lotions, everything you can imagine. People are putting cannabidiol in it, or it's called CBD. And you can get them at dispensaries in pill forms, in pill forms, in drop forms, etc. And I'm going to take 1 second just to mention this, because I'm not going to get to this in this talk, but I usually say how many people have heard of CBD and have used CBD before, but I can't see you, so I don't do much of that in these Zoom talks. But this bottle of pills, there's 30 capsules, and they're 20 milligrams each, which is 600 milligrams total, right, if you do your math. Well, when they run studies on CBD with anxiety, pain, etc., the dose they start testing is 600 milligrams. So if you're out there buying CBD products and taking 1 or 2 pills, in the research world, when they're trying to find effects, they're starting with the whole bottle at once. I'm not recommending you use the whole bottle, but just think about that when you think about CBD and the amounts of CBD in these products and the effects that are supposed to be had by using the CBD product versus what people are looking at in research studies. You can ask me more about that later, but I'm going to forget to get back to that, so I wanted to mention that. All right, so let's get back to that original slide. And the reason I put this back up is because I added something to this slide, and I added THC-laden. Because if we're talking about what they were talking about in the National Household Survey, they were talking about marijuana or cannabis products that have THC in them, meaning they get you high. So when we're talking about addiction, consequences from marijuana, it's always THC-laden products. And so I try to remember to put that in my slides. And when you want to talk about people, make sure they're talking about THC products versus CBD products. Okay. I have one slide on cannabis industry, but it's probably going to come out of my mouth a few times, is that there's a cannabis industry out there. And if you're worried about the alcohol industry, the tobacco industry, big pharma, the cannabis industry is pretty much along the same lines. There's lobbyists in the federal government, there's lobbyists in the state government. They're out to develop an industry that's out to make money. And so when you're getting information about cannabis, know that there's a lobby out there trying to push cannabis on the world to make it a big business and to make money. And the way they make money is by selling you products. And so just keep that in mind as you try to understand what's going on and what to make of what you read and hear about cannabis. So now the basics. What is cannabis? All right, everybody here I'm pretty sure knows cannabis comes from a plant. And the plant has all kinds of things in it. It has over 100 compounds. Here are the major cannabinoids that are in the plant. I've listed them here. And I've highlighted the two that we've already talked about a little bit, delta-9 THC, cannabidiol, and I highlighted this one as well to just give you an example of, we've known about delta-8 THC for a long time and always thought it as a very kind of, we know it had some effects, but basically was pretty inert, didn't really do much. Nowadays, they've figured out how to extract delta-8 THC from the plant, and you can now purchase delta-8 products in dispensaries and in some stores because they claim that they're legal, and they will get you high. It's kind of known as weed light. So there's another compound out there now that is an active compound to keep your eye on. But anyway, these are the major compounds that are in the plant that you will hear about over time. The two that are most important are delta-9 THC that I think most of you have probably heard about. That's the drug in cannabis that gets you high, responsible for the euphoric effects, whatever you want to call it. Also responsible for the impairing effects on your memory, your learning, your attention. And also, if you ever get anxious, panicky, hallucinations, psychosis, that's all delta-9 THC at work. And the other thing to know about delta-9 THC is FDA has approved delta-9 THC pills for two conditions. One's for nausea associated with cancer chemotherapy, and the other is to stimulate appetite in AIDS patients. So that's delta-9 THC. And then there's cannabidiol that you hear about all the time that I was talking about, CBD. What do we know about CBD? It's at varying amounts in the plant, just like delta-9. What people used to think, and they still think CBD does, many people think it moderates the adverse effects of THC. So somehow it tones down the anxiety, the psychotic potential, and cognitive deficits. There's really very little to no data to support that. I used to think that's really what was going on, but most recently we've started to conduct studies where they give people a certain dose of THC, they look to see what effects that has, and then they give them different doses of CBD to see if it moderates those effects. And the 2 or 3 studies that are now published show little, if any, effect of CBD on the effect of delta-9 THC. So it's not really clear what CBD does, but what you'll hear a lot is that somehow it's important to have a decent amount of CBD on a product to avoid the negative side of cannabis. There may be some truth to that, but it's certainly not very clear at this point. The one thing that CBD has been shown to do is work as an anti-epileptic, and it's FDA approved for pediatric epilepsy, for types of epilepsy that don't respond to more traditional treatments. They've shown that it can help reduce seizures. Not a miracle drug, but it can help a little bit for things that don't work in pediatric cases. There's a positive trial out there for it as an antipsychotic. It's a single study. It's not a great study, but it's a decent study that makes you think we ought to keep doing research on this. And all the other uses of CBD that you've heard about, stress reduction, antidepressant, pain relief, arthritis, etc., there are no clinical data demonstrating efficacy for any of those problems that CBD is marketed for. And I'll leave it at that. The other thing to know about cannabis and the product itself and the plant itself is when you hear claims of something called an entourage effect. What is this entourage effect that you might hear about? Well, as I said, the cannabis plant has all these products in it, all these compounds in it, and the entourage effect or hypothesis is that the whole plant, these compounds together, are important to the effects you observe. So if you run a study where you just look at THC effects or just CBD effects and you don't see anything, what gets talked about is, well, that's because the whole plant and how it interacts together is important. And that makes sense, right? There's all these compounds. The interactions might be important and should be important. But the bottom line is, we know really nothing about that clinically. There are no clinical studies that show us, oh, yes, this entourage effect is what's important to study and not the specific compounds in there. It may be true, and I think as we learn more about cannabinoids, some combination will be important. But right now, there's no evidence that this entourage effect is the key to all the magical things that we think cannabis can do. A couple other things to mention about just what to think about when you're thinking about cannabis, and how to talk about it. As with other drugs, dose matters. Cannabis products come in lots of different potencies. I've just listed them. These are like, I think some I took off a New Hampshire website where you can see the potency of THC products goes from just about nothing to 30%. CBD goes from about nothing to 14%. And when you get to the concentrates, it's much higher for THC. The edibles are sold in different things. So dose is important. So we were talking about THC does this. Well, what dose are you talking about? And the other thing, just like with all other drugs, is route of administration matters. So how are you doing it? If you smoke or vape something, you get the effects right away. It gets to the brain pretty quickly. If you eat a cannabis product, it goes to your gut, and it takes a while to get the effect. And there's a warning that most people are probably aware of, is if you take an edible, you don't expect an effect for about an hour or so. So if someone has you try an edible and it's a pretty high dose, but you don't feel anything, so you take more, well, 2 hours later, it's going to catch up to you and it's going to knock you on your butt. So edible, you need to know that. We also have oils and tinctures, creams and patches. So there's all these creams and patches, and the interesting point about that is I haven't seen a study published yet that talks about what's the bioavailability from rubbing a THC cream or a CBD cream or a patch, how much gets into the bloodstream and to the places you need to have it work. There are no studies published on that I know of. So summary of the first part of my talk here, quick, is what you think it is. To make sense of cannabis research findings and to have an intelligent conversation about cannabis and to be smart personally about what you decide to do or recommend, you need to just recognize that all these cannabinoids are not the same. There's a million different products, and you have to compare apples to apples, or talk about apples to apples, or not oranges to apples when you're trying to make sense of things. The combination and mixture of these compounds in the different products may make some difference. We really have no idea at this point what difference they make. People are beginning to look at that, but do not believe everything you hear or read when people tell you, oh yes, this much CBG or this much CBD, and that helps you sleep, and this helps you do that, and this helps you do that. We have no data on that at all other than anecdotal reports from a few people. All right, so that's the definition of cannabis and things to know about, so you can try to wrap your head around it. So now we're going to move into the idea of addiction and therapeutics. How do we think about and understand those potential effects? And the first thing to point out is something that's called biological plausibility. There is biological plausibility for both addiction and therapeutics. We have this endogenous cannabinoid system in our body, meaning that there's free-floating cannabinoids, something similar to the exogenous cannabinoids that you put in your body when you use cannabis. And the cannabinoid receptors where cannabis acts are all over the brain and all over the body and pretty dense in many areas. And that's just what these slides are showing you. And these are the places where the receptors are located. And so I've highlighted this one in the middle because the reward, the dopamine system, is where we think that addiction develops. So when you take in an exogenous cannabinoid that has delta-9 THC, it acts on the receptor site in the reward system of the brain, which is the place where you develop habits, et cetera, help develop habits and things, just like any other drug that is, quote, addictive. And then they're all over the place for all the other effects we talk about, whether it's negative or positive with cannabis. There are receptors in the areas you'd think there would be. And so, thus, there's biological plausibility for cannabis addiction and problems and for cannabis therapeutics because the systems that control these effects all have cannabinoid receptors, and the endocannabinoid system interacts with them. So let's move on to cannabis THC-laden cannabis and addiction. So this is a statement I like to make and move on pretty quickly because it's been going on for a long time, and to me it's very clear, is that THC cannabis is addictive in every accepted scientific and clinical meaning of that concept. The scientific clinical evidence is strong and unambiguous. That's in my humble opinion, but I think it's pretty clear. All the different areas that we have research in are listed in this slide. Like I said, in the brain, the reward centers are stimulated by exogenous cannabinoids, the CB1 receptor. THC functions as a reinforcer in the human lab, and now we've learned it can function as a reinforcer in the animal lab. There's a withdrawal syndrome associated with cannabis that I won't talk about much here, but that's where a lot of my work was in the early years. When you do clinical epidemiology and you ask people that use cannabis about problems they have, they meet criteria for use disorder, which is the term for addiction. People seek treatment for cannabis use disorder, and when we try to treat them, the treatment response is modest. It's difficult to quit. There's high rates of relapse, just like all the other substances that we try to treat. So I've been putting up this slide for 20 years now. The only thing I've added recently, is the THC-laden part, but pretty much thinking of cannabis in the addictive area as more similar than dissimilar to other drugs that we think of as addictive or substances of abuse. People like cannabis or use it because of its positive and negative reinforcing properties or effects. A subset of those people who use cannabis, which is about 10 to 30% of current cannabis users, will develop some problems with cannabis that range from mild types of addiction to severe types of addiction, if that's the term you want to use. And that's the same with just about every substance we study. Who are the vulnerable populations for developing problems with cannabis once they get going or using it or misusing it? It's the usual culprits, people that are impoverished in disadvantaged environments, people with psychiatric or mental health disorders, people with physical disorders, teens, all the populations that are most at risk for problems, substance use problems with whatever drug we're talking about. Cannabis is no different. And if you think about the rural populations, the risk for consequences, again, may be increased. Why? Because generally there's fewer services for those who are disadvantaged in the rural areas. There's fewer support services for those living in poverty, and there's more poverty in rural areas. For mental health and psychiatric care, less access, lower quality, fewer options. Healthcare and specialty care for physical problems, again, less access, lower quality, fewer options. So all the things that happen in a rural population make you a little bit more vulnerable to developing a problem with cannabis, just like they do with tobacco, alcohol, etc. The other thing to note is access to quality care for cannabis use disorder is limited in rural areas. There are generally fewer services for that, fewer professional substance use treatment services. Generally, less access perhaps to quality and fewer options and greater burden to even to get that access. You have to travel a further distance. Why is this important? This problem with access? Well, cannabis use disorder, as I said earlier, is not rare. People seek treatment for it, and we have efficacious treatments for it, but just like with other substance use problems, the outcomes that we get are limited, meaning most people, the majority don't respond, and those that respond, we have a lot of relapse. So cannabis use disorder, again, similar to other types of substance use disorders. So with that, let's move quickly into interventions. So I said there are effective interventions. We've been studying cannabis use disorder interventions for quite a while now, for most of my career, which is, gosh, like I said, 25 years or so. There's been more and more literature on cannabis use interventions. I'm going to go over this pretty quickly. But first of all, pharmacotherapies. Are there medications that help with cannabis use disorder? Well, there's been a lot of money thrown at this issue or this problem, this development of medications for the past 20 years or so now, not from NIDA, and these are the potential targets of the medications that have been researched, but to date, no robust findings and no FDA-approved medications. For if you were to say, what pharmacotherapy would you use in a clinical practice, You could come up with some things you'd use, quote, off-label that might help with some withdrawal symptoms, etc., but nothing that you could, hang your hat on. So it's basically like symptom relevant. But behavioral therapies, or psychosocial therapies, there's been quite a lot of work in. And first, I'd like to just talk a little bit about for adolescents. And what I have here for you is just a list of all the different types of therapies that have been tested in clinical trials and found to be efficacious, work better than a control condition. And I don't have time to go over them all, but there's a bunch of functional family therapy, multidimensional family therapy, multisystemic therapy. Those are all structured family therapies. There's individual cognitive behavioral therapy. There's adding contingency management, we'll talk about in a second, to these different types of therapies. There's a brief intervention called the TMCU, and there's technology and smartphone delivery of interventions that's starting. So there's a whole host of things that's been researched that you could look to in the literature. There's manuals for most of these, and you can find some, well spelled out, well tested treatments for cannabis use disorder and other substance use disorder. The sad part of it, to some degree in my mind, is that even with these most effective treatments and the ones that are well spelled out, conceptually strong, these are the results, what the results look like. What you see here is 5 of the well-accepted therapies that were tested in a large multi-site trial, and the orange bars are the percent of the youth that seek treatment for cannabis use disorder and the percent that are abstinent at the end of treatment. It doesn't go over 15% for any of these 5 treatments that are all, I want to call them pretty good, but it's hard to feel like that's really a good outcome. If you look at percent in recovery at 12 months, it's a little higher, but you can see it's all under 30% or 20%. So even quote, the best treatments we have out there, we don't get a lot of great outcomes. This is one slide from the work that I've done. Let me see if I can get rid of this quick. Sorry, I'll get back to it. I think I got rid of it. Okay, sorry. Let me move back. There. Okay, this is some work we did. I think we did this study down in Arkansas. We've done this study in Vermont as well. Tested this type of treatment. And this is basically adding incentives for abstinence and teaching parents to use incentives for abstinence in youth that seek treatment for substance use disorders, primarily cannabis. And if we use an incentive system to help, where if someone's showing us that they are not using drugs, teens not using drugs via urine tests, they can earn tangible incentives. We can increase abstinence rates quite a bit during treatment. But as you can see, as we go over time, we lose the effect. But we can get them going in the right direction. And this is as good as you'll see in the literature. And this is like, once we get past 3 months, we're back to the same levels of effect that I showed you in the prior slide. I just show you that because this is kind of like the best you can see in the literature. Although, another thing to take note of, and this is important when you're talking about access to high quality treatments, there's a treatment called MDFT, and this slide is showing you that depending on the age group of the youth, if you're a younger kid, 13 to 16, multidimensional family therapy can work much better than what is compared to, which is a group cognitive behavior therapy. But for the older kids, the group cognitive behavior therapy works much better than this family therapy. So this hasn't been replicated, but to me it pointed out, and this is important for the rural population in rural areas, that if you have access to a number of quality treatments, you can start to maybe mix and match and assign possibly a better treatment to somebody. But if you don't have access to MDFT, which most people do not have access to, certainly in rural populations, the possibilities for your 13 to 16-year-old aren't as strong as for positive outcome. What about adults? The adult picture looks kind of the same. These are all the different types of treatments that I could find. I've just listed them for you here. They've been tested in controlled clinical trials. They've all been shown to be effective at some level. Most of them are kind of cognitive behavioral based, or again, adding incentives to cognitive behavioral therapy. MET is motivational enhancement therapy, a very brief treatment. So those type of things. So there's a lot of literature out there to know about, and you can get a hold of on your own. How well do these things work for adults? Well, this is again a trial of ours from 2006, which we conducted while we were at the University of Vermont. And what this is just showing is that if you combine motivational enhancement, CBT, and incentives, you get the best outcomes. So in a sense, the gold standard in the field are these middle black bars, which at the end of the treatment, about 40% of the people are abstinent, not using cannabis. Over time, it stays at 35 to 40%, which is pretty good. If you're not using incentives, it drops over time. But again, the thing I like to point out, just to make the point that cannabis use isn't easy to treat, the highest we're getting is 40%. And for most of the treatments that might be available in the community, it's more like 20 to 25%. And that's been replicated by 2 other groups. And this is kind of showing you the same thing. This is collapsing outcome data across multiple clinical trials. And the point again is, if you use this gold standard treatment, which really exists just about nowhere except in research settings at this point in time, you get 35% maybe at a year that are doing well. And if you use the things that might be more available, cognitive behavior therapy, which again isn't that available, particularly in rural settings, you're down to about 25%. So bottom line with treatment, this is the take-home message. Non-responder, there's a lot of non-responders. We need to figure out how to do better for people with cannabis use problems that come to treatment. We need to find alternative approaches that are thought of as harm reduction. Mostly we've been measuring abstinence, but are there like levels of reduction that might be important clinically? We don't have good measures for that. And the most important thing for today's talk really is, how do we transport and disseminate the treatments that actually have decent outcomes and get them to people in need? Okay, I'm already only got about 20 minutes left for questions, so I'm going to whip through a couple more things here. But one of the answers, and my home base is the Center for Technology and Behavioral Health. And what we focus mostly on is the development of digital therapeutics and the use of technology to add value to the healthcare system, and perhaps at least gain more access, and perhaps do better in terms of treatment outcomes for people with substance use disorders and other mental health disorders. And here I've just listed the positives that could be gained potentially from applying technology. You can enhance dissemination, fidelity of treatment delivery. You can reduce patient and therapist burden. You can increase the quality, reach, and personalization of care, and can be potentially more cost effective. And things are developing such that they can be useful for all sorts of substance use problems and mental health problems. Just to give you an example, this is probably 5 to 10 years old now. We decided to test the use of a computer to deliver the cognitive behavioral therapy part of our MET, CBT, CM treatment that I showed you the data on. And that's this group here. So we had 30 people. The computer delivered the therapy. We had a therapist, just like usual, deliver the therapy, and compared it to a motivational interviewing only kind of treatment, or control, very brief treatment. And this top bar, this top line, is the outcomes for the computer delivered treatment. And this is the percentage of participants abstinent. And so what we found is, if we used a computer instead, not completely, but primarily substituting for the therapist to deliver the CBT, we could get at least as good outcomes, if not better. And I'm not going to show you the data, but in terms of cost savings, quite a bit. So you could deliver the treatment, the high quality treatment, get at least as good outcomes, and do it for less and make it more available. And that's the idea behind trying to apply some of the technology advancements that are happening in the digital world. The problem with digital therapeutics is kind of the same as the problem to some degree at this point with in-person therapies, is they're not highly available. For cannabis, there's something called the ETOK system. There's a website here. It's a kind of an online assessment. It's delivered by itself. It's used by a lot of colleges. It's a good theoretically based treatment. You do a self-assessment and learn some coping skills, etc. And that can be accessed by a program and purchased and delivered to groups of people. Here I've listed some other commercially available digital therapeutics. This first one is called Reset, And it's based kind of on that same program I used in our cannabis study, but a little bit more sophisticated. And it's actually now been FDA authorized and can be delivered or prescribed. Actually, you can prescribe it and insurance companies will cover it in some states and in some areas, where it's basically delivery of cognitive behavioral intervention combined with contingency management through a smartphone. Dynamic care, same type of thing. Hasn't been researched as well yet, but the research is building, and you can go to these websites and see them, and these are available to possibly get a hold of. Something called CBT for CBT has been combined with in-person cognitive behavior therapy. Again, can be used on a smartphone or a tablet, etc. And there's another system called HS, similar. No time to really go over them with you, but they're all kind of available and potentially there for purchase to get to a provider system, and can be used as like a blended care to integrate with other programs. But since we're talking about cannabis, you should know that none of these have really been directly tested on just cannabis use disorder. All right, so let me see time-wise what we got. All right, I'm going to try to wrap up in about 4 or 5 minutes. And the thing I'm probably lately most passionate about is trying to deliver a message about cannabis as medicine. I put it in quotes because I don't believe the cannabis as medicine is something we should be talking about or really even using that phrase for. But as most of you are aware of, this is a map showing all the different states that have medical cannabis laws or recreational laws. And we're up to about 37 with medical cannabis laws. And the way cannabis works as a medicine is this, and I just summarize it in these 3 points. Our politicians or state regulators basically have now informed the public through these cannabis laws that marijuana or cannabis is a medicine that's effective for a host of medical and psychological disorders. So that's the message delivered. And those dispensing, selling, and promoting these products, which is the cannabis industry, they're the ones that tell the public and the consumer which compounds are effective for what condition. They provide education or recommendations and sell the product. And you have to remember what I tried to tell you earlier, that we don't know enough to even talk about which compounds are effective for what, because nobody's shown that they are. But you still can get that at the dispensary. The physicians and medical societies that deliver medicine in our country, most of them do not support medical marijuana laws. Although some, are very interested in cannabinoids as potential medicine, but recognize that cannabis or marijuana as delivered now, there's no data for. And last, we know again, there's this booming cannabis industry that's looking to make money. Always keeping that in mind. What do we know about cannabis and mental health and illness that I really haven't talked about much? I'm going to go over quickly. There's a review article that I mentioned right here in the Lancet that I encourage you to take a look at. There's basically scarce to no clinical evidence to suggest that cannabinoids improve depression, anxiety, ADHD, PTSD, or psychosis. And if I mean by cannabis CBD, like I said earlier, psychosis, really worth a shot. Keep looking at CBD, see if there's something there. There's very low quality clinical evidence that pharmaceutical THC, with or without CBD, can lead to small improvement in symptoms of anxiety in people that have other medical conditions. So there's a couple trials where they look at people with chronic disorders, and they try cannabis to treat the chronic disorder, and they show that their anxiety comes down, but they aren't effective for the chronic disorder. So you have to kind of decide how you think about that. But there's a little bit of data there. But the bottom line is there's insufficient evidence to provide guidance on the use of cannabinoids for treating mental disorders. And the cannabis laws that are published in each state and the regulations, they do not say anything other than you can write approval for cannabis. They don't tell you what product, how much, what dose, what regimen, et cetera, et cetera. That's all done at the dispensary level with the bud tenders. This is kind of what I just said, so I'm just going to move past that. So I'm going to get back. If you're thinking about cannabis therapeutics, I'm getting back to the same slide I had on cannabis addiction. Remember that THC-laden cannabis is more similar than dissimilar to other substances. And one of the things that makes it reinforcing, or people want to do it again, is what I've highlighted here is negative reinforcement. And we're talking about cannabis therapeutics. what we're probably talking about is the removal of aversive conditions, feelings, thoughts, and pain. So if you're feeling depressed, you're feeling anxious, when you get high, use THC laden cannabis, it changes your mood. It changes your mindset, and you have temporary relief of depression, anxiety, whatever bad feeling, even some pain that you may be feeling. You distract your brain from that. The thing to remember is all drugs do that. Alcohol, opiates, cocaine, sedatives, nicotine all provide similar types of relief. So you have to decide, is this symptom relief medicine that we should be legislating, that because you can get symptom relief from a drug, because when you're high, you don't think about your problems, you don't feel your problems for temporary while you're high? Well, just something to think about. I think this is what's going on more than likely with cannabis and medicine, especially for the mental disorders, is that it's marijuana is nature's way of saying, forget it. When you're high, you'll forget about your problems for a little bit. Why is this important to rural populations? Well, some people are talking about health disparities in cannabis therapeutics. In rural populations, rural areas, you have poor access to cannabis dispensaries, increased burden to go find where you can purchase your medical cannabis. And some people are arguing that we need to fix that. To me, this is one disparity that may be beneficial. Not having access to cannabis dispensaries may be more positive than negative. And with that, just a few final comments. Public health challenges. As you can see my bias, I think we need to demedicalize cannabis use, particularly THC laden. We're sending the wrong message to the public that cannabis with THC that gets you high is something that is good for you. We need to change that positive public perception. We need to start working on harm reduction perspectives and policies if we're going to legalize cannabis, which we are. We need to focus in on the burgeoning industry and reduce its impact on selling cannabis and increasing sales, etc. Increase access to quality prevention and intervention programs for those who misuse, get in trouble with cannabis. And we need to develop some cannabis use guidelines. What level of use is safe? What's high risk? If you're going to have a product, another alcohol type product on the market, you got to start talking about, is there some safe amount? What's dangerous? What's not dangerous? We need more information to the public on that. And with that, science takes us so far. You got to use science and common sense to try to understand what we know about cannabis. In your neighborhood, always look to champion innovation. We need more new ideas, more new programs, etc., to move people past where they are now and to get better prevention intervention programs. And with that, these are just my funding sources that I didn't mention earlier, and how you can get a hold of me if you need to. And we could take some questions and have some discussion, hopefully. Thank you for your time, and thanks for listening. And I'll stop sharing at this point.
Thank you, Alan, for sharing your expertise on cannabis use disorder. I am going to launch the poll now. If everyone could please take a minute to complete that, that would be appreciated. And you will receive an email next Wednesday with the recording and slides for this webinar, as well as instructions on claiming continuing education credits. The link to claim credits is currently in the chat. So if you would like to do that today, then feel free to access that. If you have a colleague that couldn't make it today, we are excited to be able to offer CE credits to anyone who watches the recording over the next 30 days. The process for claiming credits for watching the recording live and just the recording afterwards on YouTube is the same. Please join us for our next community rounds on December 1st from 12 to 1 p.m. called Social and Structural Determinants of Mental Health, Substance Use, and Treatment with Dr. Brady Heward. You can register now at go.uvm.edu/SDOH. And as always, if you have any further questions or comments, you can reach us at CORA@uvm.edu, and I believe we have a few minutes to take some questions. So I'll hand it over to Jenny.
Yeah, I can, Jenny, I can see them in the chat if you'd like me to take a few of them.
Sure. It's up to you, Dr. Budney, however you want to do it. If you want to just choose some, go for it.
Okay, they're very interesting. Good questions, folks. The first one is, I'm interested in how to challenge people who use cannabis in small quantities, but very regularly. This regular small quantity use doesn't get much focus. Is this an important part of the discussion? Um, it is an important part of the discussion, and it's something we know very little about. And I'm not going to give you a good answer about how to challenge people, because that's like a whole clinical discussion of possible ways to deal with somebody, and you need a lot of specifics. But what's important about that question to me is it identifies that there's all these patterns of cannabis use that we need to know about, particularly with the change to legalization and this idea that people are using it, quote, medically. And so it's possible that someone's using cannabis in small quantities, but is it high THC, low THC? How are they getting high, not high? People could be taking a cannabis dose at some level that really doesn't impair them at all, and you feel it's for their pain or their arthritis or something. And we're not sure what to make of use throughout the day. But it's also quite possible someone's using cannabis throughout the day and is high all day long and is not at optimal functioning. It is sort of checked out, not checked out. But we need to learn more about those patterns and not just think because somebody's using cannabis, they're abusing cannabis and are a problem. Even daily cannabis use, say you just use cannabis in a small amount, relatively small amount in the evening, like someone drinks a glass of wine. That may not be a harmful pattern of use any more than one glass of wine is. We don't even talk about that in our society or in our public health messaging, and we need to do that. And this pattern that you're talking about, small quantities all day long, is also one we need to talk more about, and ask the question, well, what are they really using and how much are they using? So that was a good one. There's a question about what's your understanding of why there was such a decline in cannabis? Let me take this other one first. What percentage of people become paranoid with regular use? And is this different among age groups? You know, there's not a good number for what percentage of people become paranoid. At least I've never seen it in all the research that I've read. What we know is that some users, first time use, second time use, feel paranoid, and they don't use anymore. Other people manage through it and continue to be users. And then there's a subset that instead, more than just paranoid, they get psychotic. And it's not a high percentage, but it's a higher percentage than non-cannabis users. And there's a whole bunch of data that's conspired in different ways to show that, yeah, cannabis does increase the risk of psychosis. Now it's going from a very small amount to a small amount. So it's not like we're up at 10%. We're still in the 1% to 1.8%, but we've gone up from like 0.3% to 1.8% that have a psychotic type condition. And what we think, again, think is the key word, but the best we can look at now is frequent use of high potency products. So using cannabis products that are high potency at a frequent level is what's most related at this point to the potential for psychotic episode out of a cannabis use. But that's not confirmed by any stretch, but my reading of the literature, that's the thing I'd worry about the most at the moment. And I'll just leave it at that. There's another one here that's a little more challenging that I liked. Where did it go? But I don't have a whole lot to say about it, but I'll say, and this is very common and important question that's on the minds of lots of people out there. I would think if marijuana was pushed more for pain and worries in 1995 and sooner, rather than opioids, we wouldn't be in the state of shit we're in these days. So that, you know, I don't know if that's true or not true, but what's been talked about a lot is the use of marijuana or cannabis as a substitute for opioids. And as a quote, treatment for opioid use disorder, because there's some data out there that shows there's this relationship, people using marijuana are less likely to overdose. There was a paper published on that. There was a follow-up paper that just followed for 3 more years and showed, in a sense, the reverse relationship. But plenty of people talk about marijuana as be the way they chill, and it helps them not use as much opiates or not use as much opioid medication. So that's everybody's saying, oh, opiates, marijuana rather than opiates. It's just like, oh, if opiates are so awful and people are ODing, marijuana is the answer, an answer. Well, from a harm reduction perspective, that makes a little bit of logical sense. But there's other treatments that aren't necessarily cannabinoid, that don't get you high, but we have no idea about that. When people say that, are these people getting high all day long, and they say that's how they cope, which is fine. I mean, there's nothing, quote, wrong with that, but it's not a very productive lifestyle. So there's a lot to know about that, but we can't just jump to this idea that, oh yes, cannabis should be used for opioid use disorder because somehow it helps people not use so much and not likely to OD. The data, are super weak on that. Certainly that's the phenomena that's occurring out there. Some people use marijuana to chill and keep things down, or during withdrawal, it helps take the edge off. But there are other, more pro-social, positive medicines and approaches and clinical care that can probably do a bunch more good than just saying, yeah, just smoke pot and that'll help you. It's not the end of the world doing that, but it's not the answer either. That's kind of how I like to think about that. What else is?
Maybe I'll just interject here
Sure.
briefly, that we gave Dr. Budney permission to go over by a couple of minutes. So if folks would like to stay and listen to a couple more questions and answers until maybe 1:05, we would love to have you. And otherwise, thanks so much for joining.
Yeah, thank you, those who check out. Let me just answer a couple more questions if people are hanging on. I still see 70-some people, so I guess a bunch are still here. The data showing scarce to no clinical evidence, which was my term, supporting medical value to cannabis is established and had been established before legislation in Vermont passed supporting. Okay, I think the person is asking if it's true what I said, that there's no evidence, clinical evidence, to support all these cannabis to use for these medical conditions. How did the legislature pass these laws? How did the research based like this not influence the process? Well, it's a great question, and what influences the legislative process is not always data, is not always research, it's lobbying, personal testimonials. Those kind of things tend to have more influence. Maybe that's sour grapes because I'm a researcher. Some researchers certainly testified and said things like I said today, but things still passed. And once one state passed and it's claimed as a medicine, and you have lobbyists and people, vulnerable populations, asking for this harmless drug, it just kept moving and moving and moving. My personal thought is the medical laws are the problem. And if you wanted to make cannabis available, you could have made it available with just regulations and regular laws and decriminalize it. And then people that wanted to use it in whatever way they wanted to use it would still have access to it. And you wouldn't have had to put this message out that is not supported by research and a harmful message to the general population that's actually good for these conditions. So that's just, a little bit of diatribe on my part. How much does treatment failure due to prevailing attitude that cannabis is not harmful or even beneficial? I don't know. That's a good question. I don't think we have a way to quantify that. The treatment failure isn't any more than the other substances. And the thing to remember is when you form a habit with a substance, it's hard to stop. And people's motivation goes up and down. And with cannabis, having, in a sense, less dramatic consequences than things like alcohol and opioids, it's even easier to fall back into cannabis isn't causing me that many problems, so it's really not that bad, so I'm not going to decided not to quit and go back to using. So that kind of sense always made me think that's why people, fail. But they fail with the other substances at pretty much comparable rates. But that is one to worry about when you're treating people that have cannabis use disorder and they're trying to quit, is pretty quickly the same problems that they had, they still have them, and now they just change the label that they're not problematic. That's certainly my observation in my clinical experience and trials. So that notion of cannabis being able to change the dialogue is something you have to deal with, that you don't have to deal with alcohol or with tobacco. People agree might not be good for them for those things, but cannabis, they have a backup argument that actually is helping with something. But like I said before, people could argue that alcohol does all these same things that they claim cannabis does. It helps with pain, helps, reduce your anxiety. It does all those things, but we don't think of alcohol as medicine for those things. I don't know how that analogy flies, but I certainly have been pushing that more and more just to stimulate thinking.
Thank you so much. I think we'll have to finish here. Thank you so much, Dr. Budney, for your time, and to everyone who attended for your wonderful questions. And we will be sending along the recording and the slides in a few days. And let us know if you have any questions.
Yeah, and please feel free. I'll follow up with emails if you like. There weren't that many questions, so I'm happy to do that. Or you can email me at my email. You saw what my email was. It's in the slides. Feel free to do that.
Thank you, Dr. Budney. I've captured the questions that we didn't have time for, so I can forward those to you later.
Okay, great. Thanks, everybody. Appreciate it.
Thank you.
Take care.